Good morning. Good morning, sir.
Morning.
I'm Dr. Kavya, intern studying in Amrita Institute of Medical Sciences. I'm here to present a case. 28-year-old male working in Merchant Navy. He's hailing from Kottayam with no known comorbidities, presented with the complaints of fever for past 9 days. Patient was apparently asymptomatic 9 days back when he suddenly developed a sudden onset of high-grade fever which was associated with chills and rigors. It was intermittent type of fever. It was also associated with fatigability and...
Can you tell what is intermittent?
Intermittent feeling, fever comes and goes off and it touches the baseline.
Okay.
And the difference between fever is not only 1 degree Celsius.
Okay.
So, and there is no history of headache, body pain, loose stools, weight loss, burning micturition, vomiting, abdominal pain, sore throat, or yellowish discoloration of skin or mucous membrane, neck pain, arthralgia, rash. He gives a history of travel to Nigeria 2 weeks back. Since he is working as a merchant navy, he also went to Argentina.
What is the importance of traveling to various places?
Endemic diseases are more common.
If we know that one disease is endemic in one area, we can probably know that maybe the disease he is having.
Past history, there is no history of COVID infection, tuberculosis, diabetes or hypertension. Personal history, he takes mixed diet. He complains of decreased sleep and decreased appetite and constipation for past 1 week. He's habituated to smoking. He takes 4 cigarettes per day for past 4 years, so which is equal to 1 pack here. And he's habituated to ethanol also for the past 5 years. Family history, no history of fever or similar illness in the family or neighborhood.
Okay.
Head to foot examination. General examination, patient is conscious, oriented with time, place and person. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Pulse rate was 140 beats per minute. BP was 100 by 60.
What is the temperature that time?
Temperature was 102 degree Fahrenheit.
So that pulse rate is it correlate with the temperature.
Yes,
is it correlate?
102. For every 1 degree rise in Fahrenheit, 10 beats per minute.
So it is 20 beats extra. 140 means it's high.
High.
So what do you think? Somebody is having an unexplained pulse rate which is not correlating with your temperature hike. Means unexplained extra beats.
Viral myocarditis.
Myocarditis or cardiac involvement. Cardiac muscle involvement is one of the cause. Then thyroiditis. Patient who is having viral fever, thyroid involvement can have similar finding. Okay, but mostly this is due to viral myocarditis or thyroiditis. But you should remember that dehydration in high degree fever, what is explained in books is every 1 degree another 10 beats. But suppose this patient is having severe dehydration, that can exceed. Okay, so dehydration also can occur in fever. So we have to think that also.
Head to foot examination. Scalp was normal. His eyes was not sunken. Lips and teeth was normal. There was no paranasal sinus tenderness.
Okay.
There was no joint swelling. There was no muscle tenderness also. GI examination, inspection, shape of the abdomen was normal. All quadrants were moving equally. Skin over the abdomen was normal. There was no dilated veins. Umbilicus was in the midline and it was inverted. On palpation, there was no local rise of temperature, no hepatosplenomegaly, liver border was soft and regular, inguinal lymph nodes and hernial orifices were normal. On percussion, liver span was 12 cm. Liver dullness was felt at the right 5th intercostal space. There was no shifting dullness. On auscultation, bowel sounds were normal, which was 2 per minute, and there was no bruit.
Okay.
Rest all systems were within the normal limits.
Splenomegaly, clinically?
Clinically, there was no splenomegaly.
Okay.
We did a USG, sir.
Okay.
On that, it was 13.5.
So 13.5 is just increased. So you may not get clinically. We cannot pick up sometimes. Okay. What is the importance of splenomegaly in this type of fevers?
Sir, there will be hemolysis and then there will be increase.
Most of the fever, whatever may be the fever, you can get some amount of splenomegaly. viral fever, malaria, dengue, all fevers you can get some amount of splenomegaly. But in severe malaria or chronic malaria, you get a large spleen.
Tropical splenomegaly syndrome.
Tropical splenomegaly syndrome occurs in repeated malarias.
Okay.
But even then, a severe malaria sometimes can have spleen. But this patient does not have. Okay.
Respiratory system, air entry was bilaterally equal. There was no normal vesicular breath sounds. CNS, no focal neurological deficits. Cardiovascular system, S1, S2 were, there was no.
Any lymph nodes? Palpable lymph nodes?
No, sir, there were no.
Okay. So what do you do? When this type of patient come to emergency room, what all things we have to do?
First,
he is in danger. First of all, we have to see whether he is in danger. His airway, breathing, circulation, everything is normal or not.
yes, sir. Then we will send for investigation.
If there is no airway, breathing, circulation problem, we have time. If something is abnormal, then we have to treat that. Okay, now we can send investigation. What investigation you want to do?
CBC.
You want to do complete blood count. Okay, what is a complete blood count here?
HB, WBC.
What is the finding here? So what are things you can see normally?
WBC count, if it's elevated, it's more of bacterial.
So if WBC count is elevated, more it is going in favor of bacteria. If it is low?
Viral, or it could be typhoid.
Okay, viral or typhoid. Then HB percent, any important HB and hematocrit?
Hematocrit value, hemoconcentration.
Hemoconcentration. In severe dehydration, you can get slightly elevated HB and hematocrit values. Or in patient who is having hemolysis, you can get anemia. Okay. Then platelets.
Thrombocytopenia is seen in malaria,
so many conditions: leptospirosis, malaria, dengue fever. So normal viral fever itself will have some amount of thrombocytopenia. CRP?
CRP could be elevated in any infections.
Any infection, inflammation.
Severity of the disease.
Okay. Procalcitonin?
In bacterial infections.
Okay, here it is slightly higher, 10. So that indicates some bacterial infection is there. But patient's clinical features does not correlate with a bacterial infection. So what you do?
Clinical features is not correlating.
Because patient is having high degree fever, short term history, everything is normal, counts are normal, platelets are low. You think it is viral or malaria, something like that. But procalcitonin increase means there is a chance of bacterial infection. We have to clinically rule out bacterial infection. Okay. So what investigations done again?
Other peripheral smear.
Okay. What peripheral smear showed?
It showed parasites. The thick film showed parasite.
What parasite?
It is malarial parasite.
Okay. What are the types of malaria parasites you have seen?
Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, and Plasmodium falciparum.
Okay. This patient, what are the things you observed?
So this patient, immunochromatographic test was done, and it was found Plasmodium falciparum
and vivax.
And histidine-rich protein too.
Okay.
And LDH was elevated.
Okay. What is QBCMP?
That is quantitative Buffy clot layer.
Buffy clotting. Okay. So you got a malaria case here. So peripheral smear showed malarial parasite, that is Plasmodium vivax and falciparum.
Only falciparum.
Only falciparum. Okay. So how do you treat this patient is having malaria? So it's a clear-cut case of malaria. He has traveled to an endemic area last week to Nigeria. Now he's got malaria. How do you manage?
So you can treat with artesunate.
Okay.
If it's complicated malaria, then you can give us injection.
Okay.
If more than 20 milligram per 20 kgs, you can give 2.4 milligram per kg for 5 days and see if the patient is normal, and then.
Okay. So you have started artesunate.
Yes.
Okay. If it is a pregnant lady, what drug you can select?
Quinine
is not. Okay. Here, artesunate you are giving now. Same thing can be given in pregnant lady also, not quinine. Quinine cannot be used. Previously, we were using quinine. What is the disadvantage of quinine?
QT prolongation.
Okay.
And then synchronism and arrhythmia.
What is synchronism?
Dizziness, vertigo.
Okay. So one of the most common side effect is hypoglycemia. It's a secretagogue. That means insulin will be secreted. Patient will go to hypoglycemia. So one is that. Then you told synchronism. Third one is QT prolongation and arrhythmia. All these side effects are there. Still we were using it. Now the malaria is resistant to quinine. So we are using artesunate. Okay. What type of drug it is? Artesunate. It's a Chinese herbal medicine. Herbal medicine, from that it is extracted. Okay, so that can be used. So it can be safely used in pregnancy also. Okay, children, pregnant, adult, whatever may be the condition, and resistance is not known. Okay, but procalcitonin is done. What do you suspect? What are the common infections?
Gram-negative sepsis could be associated with malaria. Since it's a
the commonest presentation of malaria with sepsis is gram-negative sepsis. But he has not gone to sepsis. He might have developed some bacterial infection. We are not seeing it. But procalcitonin elevation means there is a high chance he can develop gram-negative sepsis. How do you cover it?
You can give it with piperacillin tazobactam.
Okay, piperacillin tazobactam is a higher antibiotic. You can start ceftriaxone, cefotaxime, okay, whatever it is. It all covers gram-negative. Piperacillin tazobactam is a higher antibiotic. What is the dose of ceftriaxone?
2 gram IV.
Okay, 1 gram IVBD or 2 gram IVOD can be given. So that can be started. Then what happened to this patient?
Then he had hypotension treated with noradrenaline.
So what are the reasons for hypotension in malaria?
Dehydration.
Dehydration is the commonest cause for in any condition who is having infectious fever. What is the reason for dehydration? What are the reasons for dehydration? It can be total body dehydration or it can be intravascular dehydration. Total body dehydration is due to
after fever, sweating
and patient loses large amount of water, that produces total body water loss. Intravascular water loss is due to
hemolysis.
Hemolysis will not produce water loss. It just produces anemia. So small fenestration in the arteries, okay, that can produce vascular leak. So vascular leak is the major problem in both in malaria, dengue or severe sepsis. Okay, so you have two entities. One is vascular leak, other one is total body water loss. How do you treat it? Noradrenaline is not the choice to treat hypotension in infection. How do you treat hypotension in infections? So you know what is the reason for this? IV fluids. That is a common thing we should use. What IV fluid do you select?
Ringer lactate.
Ringer lactate or normal saline. So normally we give normal saline, but ringer lactate is equally or better effective than normal saline, because normal saline is available everywhere. So you can use normal saline. Can this patient develop hypoglycemia?
Yes, sir.
How do they develop?
The parasite itself uses this, and if you give quinine,
that also. So parasite itself utilizes lot of sugar. So this patient can be given normal saline with the dextrose. Okay, you can give DNS also. Okay, so that also can be given. But to treat the hypotension, we have to give bolus dose of normal saline, 20 ml per kg. You can start, then continue infusion. If the patient does not improve, only you start noradrenaline. Otherwise, noradrenaline is not a good choice initially. Okay, if patient BP does not increase or improve after noradrenaline, what do you do?
Midodrine.
Midodrine is a weak drug. It cannot be started in acute condition. It can be started while weaning off the noradrenaline. Steroids should be started. If the patient BP does not improve even after fluid noradrenaline infusion, then you can, to maintain the BP, you can start hydrocortisone 50 milligram IV 6th hourly. Okay, so that can be given. What happened to this patient?
Now his fever
is improved. Okay. What are the complications of malaria, you know?
You get cerebral malaria, where you'll have altered mental status. You can also develop convulsions. And then GCS will be less than 11.
What is the reason for cerebral malaria? Why do patients develop cerebral malaria? Which type of malaria? Falciparum. Why do they develop cerebral malaria? What is Rosette formation?
The cytoadherence.
Cytoadherence, and the RBCs will stick together and blocks the microcirculation even in the brain. It can occur in any organ, but in brain also it occurs. So patient develop microthrombi and develops problem in the brain. They can have altered sensorium, seizures, coma, and convulsions. Anything is possible. Okay, so one is cerebral malaria. Then
hypoglycemia.
Hypoglycemia we explained.
Then algid malaria, black
What
water
is
fever.
algid malaria?
Black shock and sepsis.
Okay. Then
Then metabolic acidosis,
metabolic acidosis is due to
lactic
acidosis. It's mainly due to lactic acidosis.
Then patient can have hypoglycemia,
You told already. Platelets,
thrombocytopenia.
bleed, all these things. Then renal failure. Some patients can, like you told, stroke. Patient can have renal failure also. Any organ can be involved. Liver,
Liver failure can go.
malarial hepatitis. Creatinine can elevate. Like that, liver can also involve. Malarial hepatitis is common. Any problem with cerebellum? Cerebellitis, like you got the stroke or encephalopathy, patient can have cerebellitis also. Almost all organs in our body can be involved. Which malaria is more dangerous, falciparum or vivax?
Falciparum.
Why?
Because it affects all stages of RBCs.
Okay, one you told rosette formation is common in falciparum. Second one is it affects all types of RBC. So every group of RBC will be involved. More hemolysis occurs, more involvement occurs. Okay, what is the reason for this intermittent fever in malaria?
Merozoites released from the liver.
Okay, every 48 hours or 72 hours, the RBC will release large amount of malarial parasite that produces chills, rigor, sweating, all those things. Okay, now how do you treat vivax malaria?
Chloroquine.
Chloroquine is mostly resistant in our country. If we are giving chloroquine, what is the dose?
600 milligram stat, then 4 tablets. It is a chloroquine sulfate.
It is chloroquine sulfate. 250 milligram chloroquine sulfate in that 150 milligram base.
So 4 tablets. Then you give it as 300 milligram in 6 hours.
2 tablets.
Then 150 milligram base.
Okay. What is the advantage of chloroquine in a patient who is having fever?
Anti-inflammatory.
It's an anti-inflammatory, so fever also will subside. If you are starting chloroquine, most of the patients will recover very fast in terms of their fever. But since malaria is resistant, they may not respond to that malaria part. So you'll have to start another drug. In India, malaria is resistant to chloroquine. So what drug you can use?
You can use sulfadoxine.
Same artesunate. So vivax also we give artesunate. Falciparum also we give artesunate, because if it is chloroquine resistant, mostly it will be quinine resistant also. Okay, in our country both are resistant. But to prevent repeated episodes of malaria, what other drug you can start?
Other than
hypnozoids, to prevent hypnozoids and
Primaquine.
What is the dose of primaquine?
1.25 mg per kg.
15 milligram tablets are available. So that should be given for 14 days. What is the side effect of primaquine? Any patients you should be careful when you are starting primaquine. G6PD deficiency, they can have hemolysis. So what do you do if the patient develops hemolysis? So you are starting a patient with primaquine unknowingly. We are not testing all the patient. Ideal situation is you have to test the G6PD deficiency and start primaquine. But we don't test because it's very costly investigation. Suppose the patient develops hemolysis, their urine will be red in color. What do? You stop the drug. That's all. You stop the drug, because if the patient develops hemolysis because of primaquine, just stop the drug. Okay. What are the other antibiotics which has got anti-malarial activity?
Doxycycline
has got
clindamycin,
azithromycin. So many drugs have got antibiotics have got some anti-malarial, but they are not first line drug. They can be added with quinine or something. But when you are using artesunate, we don't add any other drug, because resistant to artesunate is not well known. Okay. So then what are complications of malaria?
Other than this, ARDS can develop.
Then how is this patient now?
He is doing good, sir.
He is doing good. When we can discharge the patient?
After.
Once the patient is able to take oral tablets, if there is no hypotension, we can discharge the patient, because it's a falciparum malaria. We no need to give even primaquine after the initial treatment. But the problem is, whenever you have a patient like this, most of these patients will have associated vivax. So most of the patients you are examining and getting a falciparum in the slide, you can also have the same patient also can have vivax, but we may be missing the organism. So it is better to continue the primacin prophylaxis even this type of patients, because we are seeing under slide. Okay, so we have to see hundreds of fields to make a diagnosis. The pathologist has to give hundreds of field. Okay, so if we are missing sometimes vivax, we have to continue it. But what you told, QBC and all, it is very easy. We can easily pick up. Okay, but we are seeing only peripheral smear. It is very difficult. Okay, thank you.
Thank you.